about different topics today. So moving on to the last topic. While managing diabetes, managing glucose only comes up to 30%, but preventing complications and how to treat that, how to detect these microvascular and macrovascular complications before they set in, that becomes the cornerstone of treating diabetes. So to talk more on the topic, detecting early signs of diabetic retinopathy, I welcome and introduce Dr. Devin Prabhakar, consultant ophthalmologist, Diabetic Eye Hospital, Trivandrum, Best Doctor Awardee, Government of Kerala 2013, Traveling Fellowship in Glaucoma, Royal Victoria Infirmary UK in 2005, Travel Fellowship in Glaucoma, World Glaucoma Council, Ratan Tata Fellow in Advanced Cataract Surgery, Shankara Netralaya, Chennai, and PADA Certified Autonomous Open Water Scuba Diver. So over to you, sir.
It's always a pleasure to be back here at JPEF, and this time the scientific committee has given me a very interesting topic. Basically, they said I spy. So how can we detect diabetic retinopathy early? And instead of going for high-tech things now, let me start off with the very basic things. So initially you suspect that the patient might be having diabetes when he comes to you with a normal stye, especially if it's recurrent stye or even recurrent conjunctivitis. That's the symptom that usually a patient comes with. So the talk is basically on the science, but I'll start with the symptoms. But apart from that, there are not many symptoms that a diabetic retinopathy patient can have in the initial stages. Like if you have got very early cataract, only a small speck of cataract in the eye, the lens turning opaque, that can cause glare and halos. When you drive at night, when you look at a bright light like where I'm standing now, you have all these lights here. All these can cause glare and halos. But a diabetic retinopathy per se does not create too much of a symptoms. If you have, in later stage, when you have a vitreous hemorrhage, when there's bleeding inside the eye, you can see blood actually coming down, like a red curtain coming. That would be a vitreous hemorrhage. Or in diabetic macular edema, you can have certain areas of defocus. Like if I were to have diabetic macular edema, I might not see the person standing here with the camera, but the rest of the things would be very clear. Now when we come to the signs in diabetic retinopathy cannot be picked up with the naked eye without instruments, because you need to peek inside the eye, look directly at the retina to see diabetic retinopathy. And it is very easy to peek inside the eye because the eye is transparent. We start away with the transparent cornea, behind that we have the transparent lens, and then we have the retina where we can directly see the middle-sized arteries, which is why all diabetologists, even cardiologists, depend upon an ophthalmologist to get a view on how healthy the vasculature is in the eye. And because we see the eye, the same changes happen in the kidney, the same changes happen in the brain, the same changes happen in the throughout the body. So what I see, what an ophthalmologist sees, is the picture throughout the body, and certainly that makes it very important to be able to pick out the smaller signs that are there. The smallest thing, a pointer. I can use this pointer. Anyway, that doesn't matter too much. Okay. The smallest thing that you can see is basically a microaneurysm, which is just a dot on the retina, which might be difficult for even an ophthalmologist to pick out. But the funny thing is, when I was delivering this talk maybe 2, 3 years, 4 years back, I was saying it was difficult to pick out. Now it has become extremely easy because we have got artificial intelligence that is coming in healthcare in a very, very big way. So these images are getting much more clearer. The images are getting refined. So if we were to take our own photo on our mobile phone now, add a filter, we will all look very glamorous. We were not all this pretty or glamorous 4 years back. The iPhone makes us much more glamorous now because we got very healthy algorithms that adds beauty to our face. Just like that, they enhance the images so we are able to see very clear pictures. And so certainly the future is very bright for ophthalmologists that is trying to look up diabetic retinopathy. And when you look at, I'll just rush through the risk factors for diabetic retinopathy. This is where you need to be more aware that you might have a retinopathy for patients. So if the patient had diabetes since a long time, he developed diabetes at a younger age, the diabetes control is not good, the HbA1c levels are way off, the hypertension, nephropathy, hyperlipidemia, obesity, anemia, everything is not very controlled, or the patient smokes, or he had a recent history of cataract surgery, then his chance of developing retinopathy would be very high. So I have borrowed heavily from this excellent online resource that is available. I think we are all fortunate to live in an era where information is freely available. Maybe 10, 20 years back when I was a houser in Dr. Jodhesar's unit, very few people had access to a journal. And he used to have this journal club wherein he used to get journals, get the summary and give it to us so that we could also learn what was happening internationally. But now all it takes is ask ChatGPT a question, prepare a slide share for me on the latest, and you get it here. So all this is available, and I have borrowed heavily from this 2025 guide. I think that is the best resource that you can go to for any doubts on diabetes. And it says that diabetic retinopathy is a highly specific vascular complication of both type 1 and type 2 diabetes. And there's a prevalence that is strongly related to both the duration of diabetes and how well the diabetes is controlled, which is why we are all here at JPEF talk to learn how we can control diabetes in a much better fashion. And these are recommendations that are relevant to my talk here. We need to reach glycemic goals to reduce the risk and slow down the progression of diabetic retinopathy. We also need to reach blood sugar, blood pressure and lipid goals. And only one caveat here, once we start initially to heavily control the HbA1c levels, there might be a slight progression of diabetic retinopathy, which is why all diabetologists send their patient to an ophthalmologist to get an opinion on the eye status before going for intensive glycemic control. And this is another recommendation from the American Diabetic Association that is relevant to our talk today regarding retinal photography. So initially when I did this talk around, I think we acquired the basic fundus camera around 5 years back. At that time, the talk was totally different because the algorithms were not very strong. The image quality was not very strong. But now things have changed dramatically with the high quality images that are there, that is being analyzed sequentially by the software, by big data analysis that gives you a very clear picture on what is happening now. A talk 10 years back would have been on direct ophthalmoscope, where as a house surgeon or as a first year PG, I was using the direct ophthalmoscope to see the retina, which as a senior ophthalmologist nobody ever does, because in a direct ophthalmoscope you get only a single eye view, which is not three-dimensional. When you talk about macular edema, which is a rise from the basic surface, a new vessel rises away from the retina. So all these are rising above the retina, and you definitely need a three-dimensional view to observe it thoroughly. Even 2 years back, my talk on retinal fundus camera was just rushing through the slides. It is a good thing, it's innovation, but it will never get better than a doctor. But things are changing very fast now. Recently we installed our latest machine, and the image that we get from this, look at this fundus, it shows right up to the periphery. You can zoom it to any level you want, and a pinpoint, dot, anything that is on the retina can be easily picked up. And I am pretty sure even now the computers are much better than humans in picking it up. Another 2-3 years down the lane, probably we will just look at the report and not look at the patients or at the images also. Initially, 2-3 years back, we stopped looking at I generally did not need to look at the patient, I just need to look at the images. Now probably I'll start not looking even at the images, I'll be probably looking out at the analysis from the software. Actually, one doctor was telling me that she got her MRI brain done, and she asked for the AI generated report, which she found to be much more accurate than the doctor generated report. I think the doctor would have used the AI anyway, but that's the way things are going. And that's why I was saying that our Dr. Jodev's dynamic team has certainly given me a very interesting topic, I spy, because the spy is becoming much, much more smart. And this is the OCT. This is an old photo. It's around 10-15 years old. I took this photo. That's actually my mother-in-law, and getting her eyes scanned, and my daughter is standing by her side. And this around 10-12 years back when we got our first OCT. And this is the one below is the one we just installed last week, which is the latest machine with built-in AI and with all the high-speed networking, because we have networked the hospital with fiber optic cable. So the image reaches in real time to my wife. She is the retinal consultant in our clinic. She gets a 3D image. Everything is done very fast, and the analysis happens very fast, and it can even be accessed from the cloud also. So what you get with an OCT is like a histopathology slide, where you get an in-depth analysis of all the images. And if you look at it, even looking at this photo, you know, this side looks normal, this side looks abnormal. You see funny things that are there. And all these funny things that we pick up can be much better picked up by the machine, and which will say as we go forward whether it is deteriorating, improving with the treatment given. And I'm coming to my last few slides. This is one of the important slides which we remember from our anatomy. People ask me, how bad is my eye? How strong is my eye? So even if your 90% of your retina is okay, but just your 5% is bad, and that 5% happens to be the macula, you will not be able to read or write or see a human face. Because the macula is only a very small part of the eye, but that has the most nerve fibers, and that is required to recognize a person's face or to read a book, which is what we all want. So if I want to do this presentation, if my macula is fine, I can see my laptop, I can see all the things there. But all the peripheral things that add dynamicity to that, life to my images, that is 90%. And I've kept this slide towards the end of my talk. Why this slide? I used to keep it at the first. Why this talk on I spy is important, but I kept it at the last because the way things are progressing, even maybe our iPhone would be able to pick up a retinopathy in no time if what Elon Musk and everybody else is predicting. The iPhone will be soon replacing a lot of things that we do. 22% is that global prevalence of diabetes, with 77% of type 1 having diabetic retinopathy and type 2 25% of people having diabetic retinopathy. And 50% of diabetics have some eye disease, maybe a retinopathy, maybe cataract, maybe glaucoma. Diabetics are 25 times more likely to go blind, 2 times more likely to develop cataract and glaucoma, and cataract can develop 10 years earlier. In my current practice, I see a lot of people in their 40s and 50s getting operated upon by cataract. Previously, my patients used to be older than me, but now they are getting younger than me. One thing, I'm getting older, but still the age that people are getting cataract is becoming less, because a lot of people, like the previous speaker was saying, are having diabetes now. So these are the various classifications that are available online, and anybody can get this slide with just a Google search. So I will not be repeating what is freely available to every one of us online. And these are the images that were generated by my fundus camera around 4-5 years back. Like from the previous photo that I showed, you can see that the image quality even for the lower end cameras have increased dramatically. So all clinics can actually think of getting a fundus camera if you have adequate patient load. You can collaborate with a nearby ophthalmologist to send these images across, or even the AI will be able to pick up basic things. And better than getting no imaging done, better than not seeing an ophthalmologist would definitely be to get a imaging done, and then share it with ophthalmologist if you pick up something. Fundus fluorescent angiography used to be done several years back where you inject a dye, but even that is being taken up by the OCT, which can now image real-time flow of blood vessels. And right now it is not at a very advanced stage, but soon I'm sure even imaging real-time flow of blood through even a blood vessel would be directly visualized soon, and cardiologists like Titus sir would be coming to our OP, looking at the blood flowing through the vessels and then extrapolating that to the cardiac data to see how strong the heart is, whether they need a blood thinning product, things like that. I think that definitely is the future. And follow-up would be annually for all diabetic patients, 9 months for mild NPD, and goes depending on the severity. And just 2 last slides, because a lot of diabetic patients might be asking about intravitreal injection, which are injections given to the eye to prevent macular edema or proliferation. Even though you say injection into the eye, it is not basically very painful, because the eye sclera wherein we inject is not a very supplied with lot of nerves, so it would not be as painful as getting an injection into the eye would seem like. And before every injection we do get a fitness done. And I started with the very basic stye, then we went on to conjunctivitis, then we went to the hi-fi artificial intelligence, we talked about retinal imaging, how software is helping us, and coming back again to the basics. You don't need fancy equipments to pick out certain things like subtle retinal edema or even aging macular degeneration. Just take a lined book that school students use for mathematics. Look at that, close one eye, look in the center of that. If the straight lines turn curvy, some of them are not clear, that is actually testing your central vision. And even with jugaad, as they say in India. So what is a 1 crore machine might be replaced by a 1 paisa note paper if, you can't, worst case scenario. And this is the last slide. The future is definitely going to be AI, data analysis. Doctors are going to be empowered. A lot of people ask, what is going to happen to ophthalmologists? If, previously I started off with a direct ophthalmoscope, went to an indirect ophthalmoscope, then I started looking at the TV screen on images. Now with AI coming in, probably I'll just read a report and say, yeah, you need an injection. Then I'll probably pat him on his back so that he feels a connection with me. I'll take my direct ophthalmoscope again and then look into his retina so that he feels cared for, that he has been seen by the doctor and not just, the report seen. So that would definitely be the future. And it's always wonderful being here. Junaid Diabetic Center, his professional team has always in the forefront of educating all healthcare workers, right from medical students, lab technicians, to dietitians, and everybody that is involved in comprehensive diabetic care, so that we can work as a team to ensure that I think the HbA1c target is now 6.4 or 6.5, stays like that, and an ophthalmologist like me will not have too much of work to do apart from saying a report, this is good, your diabetic daughter has done an excellent job, and the iSpy says that your imaging is perfect, please come back after 1 year. Thank you so much for having me here.
Thank you for that wonderful presentation. How often should a diabetologist send a patient to you for screening for retinopathy? So especially for an asymptomatic patient. You said the symptoms is gradually progressing. The patient may not have any symptoms.
Yeah, the recommended schedule is for all diabetic patients, type 2 diabetes, you need to send them at the time of diagnosis, because we are not sure how long the patient might have diabetes. So it's the first time. And if everything is normal, we generally say, the American Academy of Ophthalmology says, review every year for all diabetic patients. Once a year for all diabetic patients. Every year. That is the recommendation from the American Academy of Ophthalmology. They have a slogan which says, check yearly to see clearly. So, if you are not able to, the previously one issue that a lot of people faced, especially doctors, they are all busy in their practices. They don't have one day, they can't afford to be away from the clinic for one day to check their retina. So if the society has got 20% diabetes, we can be pretty sure that among doctors it will be around 20 to 40%. So when you go to an IMA meeting, I'm sure 30-40% of people are there are diabetic. and they don't get their eyes checked. But in their busy practice, what they can do is get an eye photo done. So each year, the imaging is getting excellent. So if you can't afford to spend 1 or 2 hours or half a day getting your eye dilated, getting it checked, you go to any, we have got lots of very competent doctors with lots of very well-equipped eye hospitals in Trivandrum all over Kerala. So you walk into any center, get your fundus photo done with a very good machine. It will give you a beautiful printout, or you can give you a digital copy, and that's all that is required. And if you don't suspect anything else, maybe once or twice a year, if your retina is okay, that is not as per scientific data, but as per personal experience, which is again not a very good way to treat patients, because you are supposed to treat on evidence-based medicine.
So, by using a device, without dilating, can we take the picture of the
You get beautiful images. The photo you show, most of them were taken without dilatation. So what I am saying is, each time I give a presentation JPEF, the contents, even though the basic thing remains the same, the quality of image, just like the JPEF, if you remember the JPEF from 10 years, the audiovisual systems from JPEF with these slide projectors, JPEF has come a long way. Just like that, the imaging has come a very long way, and I think it's going to go in an exponential way now with AI also coming in. So it's not just data analysis, the refinement of the picture, just like you take a photo on your iPhone. The photo you took on an iPhone 5 years back, Dr. Junaid would be looking much more handsome now. You are handsome, but you are more handsome now because the software is enhancing your handsomeness. Just like that, the images are getting enhanced, the data analysis is getting much, much better. So as we go forward, the requirement, even now, I have not had a dilated eye checkup recently. I basically depend on, for my own eye, I'm getting my imaging done. I mean, you can, the latest generation OCT scans does a retina scan, it does a glaucoma scan. You can get a fair idea of whether the patient has got cataract also. So if you can't really afford the time to undergo a dilated checkup, this is not a recommendation, but this is what you could do.
Sir, one more question.
So it comes built in with all the latest generation machines. It is the machine itself generates. So if I got a sequential 4 scans that is taken at 50, 55, 60, the machine now starts predicting what the vision will be at 60, 65, 70, 75, 80 years through a line now. So basically, if I expect the patient to live up to 85 to 90 and his vision is deteriorating, then I would be more aggressive in treating him than an 80-year-old patient with a fairly stable vision. So this has been there for a long time, but it is getting more and more robust, and it's getting more and more powerful now, and more reliable actually. So last time I got a retina photo, and the same photo, but the image quality was astounding. It is like taking I think iPhone 15 is the present generation now, comparing a photo taken in iPhone 10 or maybe 15 like that. Even I use Samsung phones. But even my Samsung phone from 5 years back, and if you compare it to the recent, the picture quality resolution, everything is astounding, and it's going to be much more clearer. I did not answer. Are you talking about imaging or whether I would?
Sir, he is asking about vitreous hemorrhage. Any patient who is having vitreous hemorrhage?
But there is no way. The American.
Not necessarily vitreous, diabetic retinopathy.
Sir, but there are yeah, I was going through the.
They have pulmonary disease or CV. What anti-infectives? Can you continue that?
I was going through that. It's given very clearly in the guidelines that is there in 2025. I think in 2024, Jodhya sir had a talk, a special session on the guidelines. It doesn't say stop for any indication, stop echospin for any indication in diabetic retinopathy. So it actually comes built in. I think the very basic fundus camera that you can have is your iPhone, which you have anyway. Then you have that attachment that comes with it. That is a plastic piece with an objective lens. Would be around 50 to 60,000 rupees. And then you have the analysis software. But if you want a full-fledged system, it is around 2 to 3 lakhs. For MyCam is there. Then Remedio system is around Then Vogue makes very good machines. A full integrated system would be around, I would say around 3 to 4 lakhs. But you can even get it done almost free. Like once I was in Maldives, my indirect conked out. I was using my phone with a lens, a converging lens. A converging lens costs around 30,000 rupees. You can actually get a fundus photo with your iPhone, with your indirect lens, without any other equipment. But the dexterity required is quite tremendous, and then you would need to dilate the patient. But you can, the cheapest I would say would be 30,000 rupees. Or if you go for an Indian lens, it would be around 10,000 rupees.
We will conclude, sir. Thank you so much.
Thank you.
Thank you, doctors. That brings us to the end of today's session at Nila Hall. Thank you to all chairpersons, speakers, and participants for making day